I like to present a simple study supporting the improvement and management of prescribing for UTI. This is a short presentation on the results and unintended consequences from a cluster randomized intervention to improve the quality of antimicrobial prescribing for UTI in Irish general practice. This study came along when we found in our 2011 study that GPs prescribe a wide variety of antimicrobials. We found that GPs were frustrated as they did not really follow guidelines, did not have information on local resistance patterns to interpret them, and were unable to find all this information. So we set out to design an intervention. We wanted this intervention to be easy, worth their while, and sustainable. To make it worth their while, we had to find out what was important to them, like for instance the local resistance patterns. To make it easy, we set the study up with remote data recording and extraction. And to make it sustainable, we had to make it stick and straightforward. The intervention started with a coding workshop, during which all participating GPs were shown the importance of coding. From then on, we asked all GPs to code all patients with suspected UTIs with a U71. The practices were then allocated to 3 groups. Group A had a workshop during which the antimicrobial prescribing guidelines were discussed, and due to the high resistance to trimethoprim locally, nitrofurantoin was shown to be the first-line antimicrobial. Group B received the same workshop as Group A, but also received information on delayed prescribing for UTI. The third group was a control group, and at the end of the intervention they received all the same information as the other groups. All U71 consultations were then remotely extracted and the intervention was evaluated. What we wanted the GP to do was to code every UTI patient with a U71, and if the GP would consider an antimicrobial, we wanted them to prescribe nitrofurantoin. In return, they received a practice-specific audit report in which antimicrobial resistance and prescribing for UTI was shown in relation to the other participating practices. A total of 30 practices participated with 71 GPs who recorded a total of 3,314 UTI consultations. As far as nitrofurantoin prescribing, this went up by more than 20% in both Group A and Group B, and only saw a rise in the control group after the intervention. The intervention turned out to be easy for the GPs, worth their while, as they received an audit report that could serve as part of the requirements to maintain their professional competence, and sustainable, as results were still visible 5 months later. However, not only did the GP prescribe better, they also prescribed slightly more, which was an unintended consequence of the intervention. In conclusion, we can say that before the study, out of every 50 consultations for UTI, 32 received an antimicrobial, of which 13 were nitrofurantoin. After the intervention, this changed to 39 antimicrobial prescriptions, of which 32 were nitrofurantoin. I hope you enjoyed this short presentation. If you'd like to know more about this study, you can find the full paper in the Canadian Medical Association Journal of November 16, 2015.